Screening for ovarian cancer has been an area of interest for many years, and it's also been a challenge in terms of trying to identify whether there are tests, particularly imaging studies, that can be applied to screen for this disease. When we screen for disease, we have to be aware of the fact that the screening test in some way sort of fits the biology of the cancer. In other words, is there a precancerous state that we may be able to detect before an actual cancer develops? So the best example of that in terms of the reproductive tract is cervical cancer, because we've had the availability of pap smear screening and the sophistication of improvements in pap smear screening, transitioning away from taking specimens and spreading them on a slide to what are called liquid pap smears that developed years ago. And then we've had the addition of DNA testing that brings sensitivity to a higher level. Unfortunately, in ovarian cancers, there has been no great breakthrough as far as the screening test. When people have tried to do this, they've experimented with taking large numbers of patients in the population and saying, well, let's do a pelvic ultrasound study. And when they've done ultrasound studies and looked at this in academic centers, the overall conclusion was we're kind of looking for a needle in the haystack. And we end up finding other conditions, benign ovarian cysts, misinterpretations of growths from other organs. And as a result of that, you end up identifying a much larger number of patients that you have to further investigate with either more imaging studies or take them to surgery and find out that you're really not dealing with ovarian cancer in very many people. So when you screen for a particular disease process, you have to worry about the sensitivity of the test and maybe even more so the specificity of the test. And the specificity is essentially the false positive rate. And ovarian cancer is not really a common disease. It is a very problematic disease because amongst gynecologic cancers, it's the most lethal cancer. And it's because of a number of factors, but the fact that in most instances we're dealing with advanced stage disease from diagnosis. So people have looked at screening and said, well, let's perhaps do another kind of test. If an ultrasound isn't going to give us the level of sensitivity, maybe we can screen with an MRI. It's a very expensive test, a lengthy test, a test that has certainly not been studied as a screening tool in this disease. But I would warn that, again, going back to the biology of the disease, the problem is that we're probably not dealing with a condition that has a precancerous correlation on imaging. What we've learned by taking individuals at high risk is that what we have traditionally called ovarian cancer over the years is probably to a large extent fallopian tube cancer. And this information largely derived from the ability to do more and more advanced genetic testing. And by testing individuals for BRCA gene mutations and other mutations, we can identify patients who are theoretically at higher risk for so-called ovarian cancer. And when these people were identified, they came to what was termed risk-reducing surgery. And we still do this kind of surgery today for people with these kinds of mutations. What they found was that as more and more patients were undergoing these surgeries and undergoing the removal of their ovaries and tubes, was that they could actually find what appeared to be either precursors of cancer in the ends of the fallopian tubes or early stage cancer in the fallopian tubes. And so it became clear on an anatomic and molecular basis, analyzing these specimens, these tubes and ovaries that were removed for patients in a risk-reducing setting, that much of what we were calling ovarian cancer was probably a cancer of the fallopian tube. And so that's impacted treatment for people who decide, for instance, that they want to have a tubal sterilization, or what we used to call a tubal ligation. People don't typically do tubal ligations anymore. What they actually do is they remove at least the distal part of the fallopian tube, because that part of the fallopian tube is felt to be where many of these cancers of so-called papillary serous type actually arise. And because the end of the fallopian tube sits atop the ovary, it was always an issue that, well, if a growth developed there, pathologists would say, well, this is ovarian cancer, and clinicians would say, yeah, we're treating ovarian cancer. So the disparity was, years ago, we had thousands of cases of ovarian cancer in this country and maybe 500 cases of fallopian tube cancer. And now it's very, very different. Now pathologists are clued into really identifying and classifying these as principally fallopian tube cancers as opposed to ovarian cancers. But they're the same disease, but thought of in a different way based upon these surgeries that were being done for risk reduction in so-called high-risk patients. Which then brings us to the other issue of, can we really focus our efforts on identifying who is high risk and therefore be more intensive in pursuing evaluation of those patients. But it is still a complex problem, and people have tried to identify higher risk patients. They've applied screening tests by virtue of blood work, looking at cancer markers, and looking even at other molecular entities to see if there are ways to theoretically identify patients at greater risk that perhaps then should be investigated as a way of either preventing the cancer or at least hopefully identifying it in an earlier stage where the treatment may be less severe and the outcomes improved.